flow. So now in this, I have made it as 3 parts of the presentation. It's a very small presentation, more like once I make the presentation, we have to discuss together and come to a conclusion about how we are going to adapt to all this situation and then get on with it.
Your presentation is not visible, Faiz. Your presentation is not visible.
I have shared the screen, sir.
Yeah, but it's looking at, to me, it's looking like a minimized mode. How about others? I don't know. Prashanth, yeah, Prashanth's mic is muted. How others can see? Now I can see a black. Now I can see your arrow, the cursor moving, but I can see a black screen. Just a black screen.
I can't see it either.
I can see a few things moving around like Corona, just on a black screen there.
It's just the it is just it is just the cursor which we see, Faiz.
Yeah,
nothing else.
I know.
Okay, just give me a moment, sir. I'm just
yeah, sure.
Mahendra, this is not visible. How do I go about making it visible? Because I made the screen share.
But then just see in that you have clicked for a blank screen by mistake.
Sure.
On the click on the right button and see. Yeah, now it's visible. Now it's visible.
Now it's visible. Yeah.
Yes. Now it's visible, sir.
Yeah, very much. Yes.
Okay. So an idea not coupled with action will never get us any bigger than the brain cell that it occupied. I found this very interesting, so I thought I'll just simply add it there. And that seems to be just one screen. What is this? Why is it not going into a PowerPoint?
And we can see the screen. Just try the arrow button, sir.
Arrow, yes.
Page up, page down. Page up or page down. One of those.
1 second. Can you see this, sir? Now can you see?
No, it's still the same slide. It's still the same
slide, but which is visible.
Just click on the screen once, just gently with your mouse, and then try the page up or page down button.
No.
Is that a PDF or a PowerPoint?
It's a PowerPoint.
PowerPoint. So it should work. Why don't you ask Nadira to just help you? I think it should.
Just try that on the escape button, but it's going.
Correct. Yeah.
Now can you see back to practice flow?
Back to practice. We can see. Correct.
Yeah. Yes.
Okay.
Yeah. Okay.
This one.
Yep.
Yeah.
Now can you see, sir?
Yes, we can see. Yes, we can see.
Okay. Sorry about that. Okay, I was pressing some other button and it was going away somewhere.
Okay.
So now, what I wanted to speak about was, I have divided this presentation, a very short presentation, into patients and doctor and assistant and to the clinic. What do we do? What are the equipments which might be necessary? What are the procedures? And what do we do? So to this, I am imagining a scenario where the patient is walking into our clinic. Okay. As soon as the patient walks into our clinic, the first thing I want to do is the pre-treatment protocol, where I want to do either we do a hand wash, if there is a provision for hand wash, or we can sanitize with the hand sanitizer, or we can glove the patient on the spot. Okay. So that is about the hand. Next is the leg. If there is any possibility of washing the leg, he washes the leg, or you can directly put a foot cover for the patient. Okay. As if some places, if you want to also, I have seen one presentation where at the entrance, the doctor has placed one very wet cloth mat on which he has put the 1% sodium hypochlorite. So the patient comes and stands on top of it and then steps into another dry mat and then walks into the clinic. Okay, so these are the 3 things that you can do for the leg. But the leg is a very important part of the cleaning, so that you do not allow anything to be carried inside. If there is a chance for having a mouth rinse outside the clinic, if there is a wash basin outside, then you can allow even the mouth rinse. Otherwise, you can just put a mask on the patient and get the patient to the reception. Once the patient is in the reception, we take a brief history. At the moment, there is no need to talk about travel history because we've crossed that time and it is really not relevant at the moment. So we can just find out about the if there is any symptoms about fever or cough or whatever. There are so many symptoms which are already you are overloaded with all that information. I'm not going deeper into that. So we take a brief history, and with that history, we can check with the IR thermometer. If this is not a conclusive thing as compared to the pulse oximeter. Pulse oximeter is going to show us if there is any transient hypoxia for the patient, immediately you can come to know within just 1 second. So if you put the pulse oximeter, if it is anything less than 90, definitely the lung is not working to the full capacity. The patient should be refused and you should ask the patient to go and get the proper test done. So if you're going to allow the patient inside, the patient has to first cross this pulse oximeter test. Okay. So this thermometer is not really indicative because if the patient is having any mild fever or pain or whatever, he might have already taken analgesics and antipyretic. So it will not be of any much consequence unless you are really checking the patient, your workers, if you're checking the workers every day. And if there is any mild difference, you can find out for a person whom you are going to see every day. And the last but not the least is the consent what you need. So when the patient walks inside, you wash the hand or you sanitize or you glove the patient. Leg, foot cover is the ultimate. If you can rinse is very good. Rinse first with chlorhexidine and then followed by betadine is super good. Mask, definitely a 3-ply mask is essential. When you are allowing a patient to come inside your practice, it is better not to allow the cloth mask. Cloth mask is just definitely not good, and it is also not allowed by the WHO. So I do not advise you to do that. Next is the brief history, thermometer, pulse oximeter, and pulse oximeter, we will take it as one of the important tests for us for allowing the patient to come in. And of course, consent is just to get us safe.
Now, Faiz, I have a comment there.
Yeah.
As far as the brief history is concerned, you had just mentioned that travel history is irrelevant. But
yeah, at the moment.
Yeah, no. I have a slight difference of opinion. See, now we are getting so many non-resident Indians who are coming in now. Yeah.
Yes.
Many of them are coming in, and not only that, inter-district travel is also permitted. Interstate travel is permitted. So I think in my practice, what I do, I request them to give a brief of their travel during the past 3 months.
Past 3 months.
3 months.
Okay.
3 months.
All
I mean, that is what I do. That is what I do.
But see, Prashanth, why I was telling that is because in Chennai itself, there are so many zones. One zone is a red zone today. Next day, they are removing all those barriers. It becomes the orange zone. So it is really difficult for you. Today, it is a red zone. Tomorrow, it is the orange zone.
That's true. Yeah.
As soon as they find a couple of people who are having fever, instantly the police is putting blockade and blocking that entire area. And it is like a containment zone.
Yeah.
Next day, they find, okay, this fellow has become negative or fever has gone down, everything is okay. They'll remove the barriers and nobody is there anymore. So that is one of the reasons. But of course, see, because it becomes more and more difficult to track.
No, that is relevant to your part. I mean, in your area, I agree. But as far as we people in Kerala are concerned, we have a lot of people coming in from abroad. We have a lot of, I mean, I'm sure you'll have the same number of.
Prashanth, if I can intervene, shall we take the questions at the end of his presentation?
Sure.
Just take down notes.
We will do that. We will not interrupt. Yes, we will not interrupt.
So the next thing is when you're, see, the brief thing what I noted down from another article was when the patient comes in, when you do an initial screening, If there are signs of any COVID, then you go into this protocol. If there is nothing, if the history is not applicable, then you perform the regular dental treatment. In case you suspect the patient for a COVID positive patient, then you need to report it to the state health authorities. You need to ask for all the relevant tests to be taken. So in that case, then the question of elective treatment comes, or you want to avoid treatment, you can only do urgent care with the pharmacological management or whatever that is. So this is one of the basic things. If anybody requires this, I can just simply give the entire presentation to them. They can just simply contact me. Next is, that is as far as the patient is concerned. So when the patient comes in, you have done all these things and safely brought the patient inside your practice. Now, what does the dentist and the dentist assistant have to do? First is the scrubs. When you're dressing up, it is best, what I have seen out of all the presentations and webinars and articles, they are telling, if you are going to have a regular scrubs which you are going to wear to your office, that is most best, because once you finish your work, you can just simply remove it. You can put it or soak it inside the detergent or 1% sodium hypochlorite solution instantly and walk away from there. So it is your choice to either have a disposable apron, or you can have a autoclavable apron on top of these scrubs. Goggles is a very essential part of the protection protocol, and once we go inside the practice, N95 is essential. Definitely no cloth mask. If there is a 3-ply mask, most of the places, if you are very safe with the patient, if the patient does not give any history, or you are very sure that the patient is not having any doubtful symptoms, then a 3-ply mask is also, surgical mask is okay. But to be on the safer side, N95 at all times is the best, definitely. On top of this N95 and the goggle, if you are going to see the patient, a transparent face shield which is covering your neck also, and definitely a double glove. So I am talking about something which is really minimalistic. I'm not talking about something which is really extravagant and something which you cannot practice. I myself personally, I feel claustrophobic even looking at that complete PPE thing which is zipped up and then you put it on top of it. And when I heard one surgeon friend of mine who said that once he wore it, it started fogging inside. He could really not see where he was even placing his blade. And he's a microvascular surgeon in Apollo. So he said he had to simply remove it, and with just a N95 mask and the goggles, he continued the procedure. He could not wear the complete cap on. That was his thing. So since I was not very comfortable with that thought, just the thought of it itself was giving me kind of uncomfortable feeling. I said, okay, let me look more deeper into it. And even according to the DCI specification, they are not talking about a complete coverage or anything. They are talking about the apron, goggles, N95 mask, and a double glove. That should suffice for us to examine the patient itself. Next is, what do you do in the clinic? In the clinic, we can do 2 types of procedures. One is the consultation, or you are going to do the basic examination. In the basic examination, once the patient has been brought inside, you have already made sure that his leg is clean, hand is clean, and the mouth is also clean. If he has already come inside, you ask him to use the restroom and have a wash there with the mouth rinse, and he has come inside. So to make sure, you once again give betadine mouth rinse and scrub the mouth completely. Take a cotton and you can scrub it down. Once you scrub it down, the entire viral load in the saliva is completely reduced. The more number of times he is going to wash. Okay. Then you take the autoclaved instrument and examine. Once you've done the basic examination, confirm only with a OPG. No need to take a small IOPA X-rays and allow the patient, in case they are going to cough or they are going to gag, that will not be safe for us. So We will confirm the entire treatment with this and then give a firm appointment. So till now, our PPE, what we are wearing is just a scrub, goggles, and a 3-ply mask. Better is a N95 mask. Suppose we are going for a aerosol procedures or any other procedure more than a consultation, I suggest for the doctor and the assistant, apart from the scrubs, you have a disposable apron, or you can have an autoclavable apron. On top of it, a face shield which will cover up to the neck. Definitely a head cap is required if you're going to do a procedure, because there will be aerosol. One of the more important procedures what I definitely advise all doctors to have is a high-speed extraoral suction, because this is a physically you are going to remove all the aerosol from the mouth if you are going to keep something, and you are going to remove it physically. So 90% of your aerosol coming from the mouth itself is already gone into the high-speed evacuator. High-speed evacuator is already furnished with a plasma filter, there is a charcoal filter, there is a UV filter, and one more sound filter is there. After the 4 filtrations, it is going to come back into the room as fresh air. So that is going to give us more amount of security. Okay. So now, apart from that, whatever the rest of the air which is going to escape from this high-speed evacuator, we also fortify it. It is not necessary, but we also have an air purifier, or you can have a negative ion charger. We can keep that as an adjunct to it, but it is not necessary. AC is on with no, because if you are going to add the HEPA filter, it is not going to work really well with the compressor. So you need to have a special air conditioner for that. In this case, we just have the air conditioner on, but with the windows open, so that there is a fresh circulation of air. We are reducing the viral load in the room definitely by just keeping the windows open. Okay, so to help us in the speed of the work, I have put this as an optional is the electric handpiece, where you will have a 2 lakh RPM will be the speed, so you can really do the work very, very fast, and it does not use the compressor. It is running on a micro motor itself. So the air running into your lines, into your room, the chance of leakage from the tubes itself is very, very less. Okay, so this is about the procedures what I thought about. Next, what I thought about was, how do you handle the airborne procedures? See, in this, there is one article which is beautifully there. In the last, I have given the articles, list of articles which I have taken all this from. You can just note it. In this, he is speaking about the barrier protection, about the mouth rinse, high volume evacuator, and finally is the HEPA filter and the ultraviolet treatment. If necessary, you can do that. If it is possible to do, you can do, but you can make do with these 3 procedures itself is, you can reduce the viral load quite a bit. You will be quite safe if you are going to wear the proper PPE and the N95 mask and dispose of all these things perfectly, then you are good to go. So what are all the PPE that we need to have? We need to have the surgical scrubs, we need to have goggles, the shield, and proper gloves. See, in the gloves itself, most of us, after using the latex gloves, the hands become allergic and it doesn't respond very well on the skin. So it is nitrile glove you can wear. On top of the nitrile glove, you can use the surgical glove, which will give more amount of security and comfort. Okay. Apart from this, you also have the mask. In the mask, most ideal is the N95. Next, in case you are only examining the patient, you can use the surgical 3-ply surgical mask. Definitely, the WHO has not advised the cloth mask at all. So you please don't think about the cloth mask at any point of time. when we look at the radius of contamination, the chair is there. Around the chair, 1 meter around the chair, you will consider it as the 100% it is contaminated, and 2 meters from the chair is 50% contaminated. So how do we clean this? There are 3 methods. We can use the benzalkonium chloride, sodium hypochlorite, or ethyl alcohol. Ideally, sodium hypochlorite is one of the cheapest disinfection solutions. If you make a 1% sodium hypochlorite, and if you are going to clean the clinic from inside to outside, that is from areas of less contamination outside, you go to the inside and clean up the inside. That is the ideal solution. Or you can start from one end of the clinic inside, deeper end, and come towards the door and clean it and take it out. Physical cleaning is what is more safer for us than using the fogger or by using fumigation or ultraviolet radiation, ultraviolet light. Ultraviolet light is going to give you ozone, which is not good. It is a proven carcinogenic. Most of the chemical disinfectants are having some negative effect or the other. Of course, I read some articles regarding chlorine dioxide. It seems to be okay, but the concentration of sodium chlorine dioxide should be less than 0.3 part per million. So the dilution of it has to be really good. Then only it is safe for the clinic people and for yourself. In this, next, once you've cleaned the chair and you've cleaned all the surrounding areas with 1% sodium hypochlorite, you need to disinfect the instruments what you have used. The instruments, once again, you can use alcohol, or you can use Sidex, which is the glutaraldehyde 2%. You can dip it for 30 minutes. Ideally, sodium hypochlorite, once again, at 1% is, you will notice, bactericidal, fungicidal, virucidal, and also it's a sporicide, and it is really cost effective. That really is playing well in my mind right now. I don't know where to source this peracetic acid, so I'm not really talking about it. In the chair, we need to first clean the handles, the chair, then finally move on to the dentist chair, auxiliary, and all the other movable parts in the chair itself. So when we are doing a preparation, you've done a tooth preparation as a lab. I have a lab by myself. I've been running it for about 20 years now. And I've been thinking about seriously, like, how am I going to receive the work from the doctor so that safely my workers will be able to work on it very safely. In that, what I did was I created 2 areas in my lab. One is the area where the technical work is going to go on. One is the area where the reception and the delivery people are going to come and interact. So what I thought was, the delivery people will come and give the work and they will stay there. They are isolated. They are not going to come inside the lab at all. They're going to sit outside in my car park. Once it is on the reception table, I want the doctors to send it all the instructions as a paperless instruction. I don't want one paper to be inside the model, because he has to open it and then read it and then write on it. So that paper, he will take it and keep it on the register, and it will, really disturb that place. So I don't want that to happen. Once it is on the message, even before the work comes, we can register it and keep it ready. As soon as the work comes in, straight away it will go inside the box of Sidex. You just simply put it inside the Sidex, or I will spray it with 1% sodium hypochlorite. What we have done is, we have bought this very cheap agriculture spraying thing for 5 liters. 5 liters of water, 50 ml of sodium hypochlorite. We mixed it and kept it. As soon as it comes, pump the pressure in and just simply spray on it. Leave it for 5 minutes, let it dry out, and then we are taking it and washing it down and pouring the model. After we pour the model, even sometimes what happens, even inside the impression, there will be some food particle inside the impression itself. So that is also an organic matter which really again disturbs me. So what I have now devised is, we have purchased a OTG and oven toaster grill, that thing. What we have taken is, I've set the temperature at 100 degrees and I've taken the model and kept it inside. Once the model is heating up for about 10 minutes inside, it's already preheated, then you take it and keep it for 10 minutes. It is definitely, I can be sure that it has killed all the virus, even if it is there, because the virus is harmless after 78 degrees centigrade. It just gets simply destroyed. So I am going to heat my models up to 100 degrees and then proceed with the work. So if this work is over in the reception, inside the lab, the entire protocol will go on as usual. So we request the doctors that I want only the rubber-based impression so that we can pour a clean model by ourselves. Or if you are taking alginate impression, you pour the model and then you give it. That model, when it comes into our practice in our lab, what we will do is we will immediately sterilize it by simply heat. I will simply put flame on top of it, burn it. It will simply remove all extraneous material, whatever is organic material is there, it will just simply dry it out and burn it. And we'll take it back into the lab to continue work. So we request the doctors to put it all inside a Ziploc cover and sanitize the outer surface and give it to the lab. And please do not allow the delivery lab people, boys, to come inside the clinic, because once again, as soon as he steps into the clinic, your clinic protocol is wasted. We don't know from where he is walking in, what he is doing, because most of the guys, in my team itself, what I have seen is, they are not really serious about it. It's like this is a summer holidays for them. They are not taking anything seriously. I have given them mask, I've given them everything. Every time they come back, they are walking in without the mask, and then quickly, as soon as they see me, they'll pick up a mask from inside the thing and wear it on. So I really don't know what they are carrying inside our premises. So I definitely decided that the delivery boys have to be outside, and I request even the clinics to follow that. And for the trial procedures, of course, when we are going to ask your lab to only send the unit without the model, because if you are going to bring the model inside, once again, it is traveling. We don't know who is carrying that model, under what conditions it is traveling and coming, and it is going to enter your place. If it is with a cover, you can just simply take the cover. Either you can put it inside the disinfecting solution, or you can put a UVC chamber and put it inside, disinfect it, and then take it to your patient. So it will be very much easier for you to handle the sterility of the work, which is going directly into your patient's mouth. So this is about the lab thing which I wanted to talk about. And finally, the simple precautions we need to take when we are going to enter the house itself. So leave all the bags and keys outside, or have for the house all these small things to sterilize. Have a small chamber of UV light, just sterilize it and then come in, wash the hands, shoes. Of course, the most important thing which we always forget, or we give more importance, is this cell phone. We need to disinfect the cell phone and these personal things, the gadgets, and definitely, like so many last time, Dr. Eapen was telling that we should not wear the watch at all in the first place. There is no need to wear the watch. Just simply remove it. And in my practice, I'm planning to keep a washing machine itself. So as soon as we remove the scrubs, I want it to be dipped in 1% sodium hypochlorite, leave it on for 10 minutes, and then straight away it goes into the washing machine and it will go into a drying cycle, and that's it. It should be done that way. So these are the precautions which I suggested. So when I sum up this whole thing, what I want to tell you is, when the patient comes in, pulse oximeter is a very important diagnostic tool, and of course the history. After that, once you make the patient come inside, rinsing or scrubbing the patient's mouth is very important. If you are doing the aerosol procedure, you need to have a high vacuum suction, definitely, so that 90% of your aerosol is sucked out there. Windows are open, AC is running, so air circulation is happening at a faster rate. So physically, what I have suggested is everything is physical. When you finish the procedure, once again, you are going to spray the chair and everything with sodium hypochlorite, wait for 5 minutes, and then with plain water, you can just simply swab the place. Again, physically, you are going to remove everything, because once you put the chemical and kill the bacteria, still the remnants of that bacteria, although it is dead, there is a mycotoxins and neurotoxins are there in that body of that bacteria. So depending upon how much of chemical that you put there, it will go on increasing the toxicity of the room, although it is not going to create an infection. Okay, so to reduce that, the more number of times we are going to physically clean our place is more important. That's what I felt. So my procedure, what I am having in my mind is a really simple procedures. I don't want to overdo anything, and I think we should be able to practice very safely and comfortably if we are going to do this. And these are the few references what I have taken, and I am now ready for questions, and we can discuss further. Prashanth.
Okay, that was an excellent presentation, Faiz, as usual.
It is just my idea, Prashanth, that I don't want to overcomplicate the whole thing. We should keep it as simple as possible and as effective as possible. That is what I want to suggest. You need to mute.
Yeah.
No,
So,
I allowed the participants.
You have to.
Okay.
Yes,
Now, Faiz, I have just two questions. I'll quickly ask those two questions with regard to the impression material, disinfection of the impressions. Can you hear me? I think Faiz is muted.
Sorry. Yes.
Yeah. Faiz, disinfection of the impressions. Now, you've insisted on using rubber base, yes?
Yeah.
And rubber base, of course, it has got excellent dimensional stability. So disinfecting with sodium hypochlorite is not a problem.
Sodium hypochlorite or glutaraldehyde 2%, we are going to put it in side X, or when we are going to use the instruments, nothing will happen. It will be very stable. And if you're taking with the alginate, better not to experiment, since you are anyway working in that atmosphere. On the spot, if you pour the model, I will disinfect the model very easily. Just heat.
Okay. That was the point which I was coming to. Probably if you try disinfecting the impression, I mean, as long as you're pouring the model, it doesn't matter at all. It doesn't matter.
If alginate, I didn't want to take a chance with the alginate because I don't know about the dimensional stability. After we do the entire work, if it does not fit, then it is of no use. It makes no sense.
Okay. Fine.
Prashanth, can I just make a few points?
Sure. Please, sir. Please.
Actually, Faiz, I have to leave because family is downstairs. They just got together on Saturday, and I also have a telephone call to make. So it was an extremely nice talk, and it more or less contextually agreed with everything I feel, which is not necessarily correct because people have different opinions. So I'm just going to make a few points, and this I'm talking to you from my practical experience. I didn't see your last slide about going home, but I will assume that I was not able to read through the whole thing. Doesn't matter. I just wrote 4 or 5 points. Very briefly, I will run through them. Okay. The mouth rinse is an extremely good idea. It may look a little messy if you have people standing around on balconies rinsing their mouth before they come into your clinic. if it's a standalone clinic. Yeah, but these are all personal observations based on my practice for the last couple of weeks. So we have a separate washroom. So we ask them to actually rinse in the washroom and then come out. You can make them again rinse. My surgical chair doesn't have a spittoon. We don't use spittoons on surgical chairs. But I generally have heard that people don't like. They are discouraged from spitting into spittoons. So I think it's a good idea for them to spit. And I think once spitting with whatever appropriate antiseptic is fine. That is a good idea. With regard to the infrared thermometers, in fact, I was having a talk with Eapen. Thermometers are necessary. I think they're standard procedures. They're being used all over the world, airports and busy places. And I'm sure clinics definitely need to record thermometers. The problem with temperature is that you can actually hide it. So, people who take paracetamol, people who have thermometers try to hide it. I have done this about 7 or 8 years, no, 10 years ago when the SARS virus came. I was in Kathmandu, is coming back. I didn't want to get quarantined, so I put a cold Coke bottle on my forehead before they did the thermal thing. So you can do it with paracetamol. You can do it with a lot of other things, as you're walking into big places. And the other problem is that if there are people who are coming with odontogenic infections, or their first post-op day, they will have a spike in temperature. So you don't want that to cloud your thing, but legally, I think you should have infrared thermometer to cover your base.
It's a statutory requirement. Yes, it's a statutory requirement.
I don't know if it's a statutory requirement, but it definitely is a legal requirement. Because in case you're caught into a funny situation. The pulse oximeter is a very interesting thing because I have about 3 or 4 pulse oximeters in my clinic. Because we have a fairly large surgical practice as well as other practices. I stopped using them some months ago. No, not some months ago, some years ago, a couple of years ago. The reason is the moment a person has a SINCO, we put the pulse oximeter, saturation is 50 and everybody is scared. It scares the hell out of people. I'm sure most dentists don't use pulse oximeters in their clinics. I use it. I've used it, but I've stopped using it. But now I think it's a good idea to use a pulse oximeter. One is temperature. It's like, the rate, your heartbeat, your tachycardia is a good indicator, just like temperature for fever. So that way it's good. But most importantly, there is, I don't know whether any of you have read this, there's something called a silent hypoxia. I saw this in the New York Times. Now, the problem with silent hypoxia is that there are several patients. Just a moment, I'll just put this fan off because it's making a lot of noise. The problem with silent hypoxia is that I understand from several case reports that there are people who have walked in looking perfectly all right with saturations of 60 and 70. I'm not talking about COPD patients and things like that, ordinary patients who have walked in and suddenly collapsed, suddenly desaturated. So I think it's one of the very cardinal signs of COVID infection that they actually don't look sick, even if their saturation is 60, 70, they're not breathless, mildly breathless maybe. So I think it's a very good idea to use a pulse oximeter. I don't know the cost, running cost now. I bought my pulse oximeters long ago.
For 2,000 rupees, sir, at the moment.
That's all. I bought it for 2,500, I think, some time ago. But I'm sure there are pulse oximeters. The reason I'm asking is because all prices have gone up because of the
somewhere around the same price, sir.
Yeah, but you should, most dentists are not familiar with pulse oximeter, so they should be comfortable using it. So there are two things. It tells you your heartbeat, it tells you your, based on capillary, your saturation. Now, pulse oximeters are very unreliable. I've been practicing as a surgeon for 35 years, seeing pulse oximeters every day. I've had bad experiences. You have people who have hyperpigmentation, thick pigments, calluses and things like that. These things don't pick up very easily. Sensors don't pick it up very easily. Sensors, if they fall down, or they are very, very fragile things, so they can give you wrong readings. So it shouldn't take you away. And then you have my normal saturation is about 94, 95 because I'm a mild asthmatic. But people with COPD may have it at 85 to 90. So whether we should use that to eliminate patients or not is a big question. So you need to be careful to understand pulse oximeter, and the handheld pulse oximeter that you have doesn't have a plexithography, which is a graph which tells you the thing. So it's not a very sensitive instrument, but it's a good instrument to have, especially if you have to detect silent hypoxia. Patients who walk in looking absolutely normal and who may actually be saturating at a very low level. I think it's a very important thing to do. Then the next one is the eye. You know, you were talking about the goggles and the face mask. I think the eye is overestimated. I looked at literature. Ophthalmic literature gives you a lot of information about possibility of eye infection going into your nose, but I think it's more like tearing which can actually affect your nose. So I think we should be careful about emphasizing too much on the eye. You need a face shield. You don't want to carry bacteria on your face. Of course, you don't want the I'm sorry, not bacteria, viruses, and you don't want viruses getting into your eye as well. It's a good, definitely they should be protected, but we are placing too much of importance on the eye. The nose and the mouth is extremely important, as you mentioned, Faiz, and I think you need to have extremely good masks to be able to protect yourself and your family when you go home, because you don't want to carry those infections home. And then the double glove. We talked about the double glove. In 1986, when I started my practice, HIV was coming into this thing. Nobody wanted to touch HIV. So everybody referred the HIV patients to me. So I become a bit of a HIV dentist, maxillofacial surgeon, whatever. We took all the precautions that we needed to take. And this is going to work on similar lines. So this double gloving, what we are talking about is actually, what we are probably thinking is that if one glove pierces and it goes in, it's not so much to do with that. The double gloving is more for the doffing process, because the doffing process requires you to take one glove off and the other glove later and things like that. It's too complicated to explain on this webinar. Yeah. So the infection doesn't spread through actually cut skins or even exposed skins. They say even with eczema and all things, it doesn't go in. So double gloving is an option, but if you have a good pair of sturdy gloves, I think that is more than adequate. I'm not contesting anything that you said. I'm just giving you my practical perspective on this. Yeah. And the OPG is a good suggestion. I think if you doesn't have very high
radiation.
Imaging
dosage, sir.
No, not the dosage. I'm talking about the amount of imaging information you get from OPG is sometimes not good for root canals and individual teeth and things like that. But an OPG is good enough to give you a general picture. So wherever you can go through the skin, don't go into the mouth. So OPG is a good option. I agree with you on that. And then the PP is much misunderstood. We talked about it a lot, so we're not really going to go into that. But is this a question I'd like to ask everybody who is listening to this? When you were practicing before COVID, were you actually practicing with an absolutely sterile environment? No. We were practicing with shirts, pants, sometimes wearing surgical scrubs or coats, perhaps, but those were not sterile. So every time they talk about PPE, they're talking about sterilized PPEs. So you really don't need sterilized PPEs. These PPEs are for your own protection. So you can wash them, dry them well, make sure the virus is not sticking on from the previous patient. But don't go in for these sterilized. They're not really absolutely essential. Everybody is talking about autoclaving and getting absolutely sterile PPEs to where you don't need it that way. And many of the PPEs that are being marketed can be washed several times. Some of them cannot. Depends on GSM, depends on the fabric, depends on whether they are woven, unwoven, and all those details, the surface treatment and all those kind of things, which we can't really go into. Way of avoiding it is don't use aerosols for 2 or 3 months or 4 months. I studied in the 80s, 70s and 80s, where we used triple section handpieces and micromotors. And as you rightly pointed out, micromotor with rubber dam is probably the best option that you have, which Faiz has very rightly pointed out. I think it's a practical point that you should take. And if you have to do it, and try to postpone all those high aerosol producing things, because all the discussion, all the hi-fi things come in relation to that. So everything else is common sense and how you keep yourself safe. I'm almost finished. Chair disinfection. Oh, I'm sorry. Chair disinfection. Now, we all hold our chairs like this. If you notice, every patient holds his chair like this. And I was looking at my assistants cleaning the chairs. They spend a lot of time on the head and the back and the buttocks and the legs and everything else. They don't spend enough time on the hands. I think the most important place is your handle. And remember, people hold it like this. So go under your handle and make sure you clean it absolutely properly between patients. Just practical points I picked up looking at how things were going on in our clinic. So I think when you tell whoever is disinfecting to do that. Another thing I realized yesterday, was that when you doff, I mean, the doffing is too big a complicated thing. One day we can probably have a session on doffing, how to take your thing off. Somebody can actually demonstrate how doffing is done. So it's very important to protect yourself. Now the problem with doffing is you roll the whole thing. It's about this big when you take your PPE off. You can't put it into a small bucket like that. Like this. So you need a big bucket. So buy 4 or 5 big buckets into which you can just dump them. Fill them with water, fill them with detergents, just dump them inside, wash it, autoclave it, reuse it, throw it, do whatever you want. But
you have special drums for that, sir. It's available.
No, it's really big buckets. I just asked them to buy big buckets. So they get big buckets and basins. They like how you bathe children in those kind of big basins. Those are fine as well. You can just put it into that. These are very practical points that you think. And I think the last one that I want, coming back home, I have this biggest fear of coming back home. I have an 85-year-old mother, a 2-year-old grandchild, my children, I mean, they all hanging around. So you made very important points in coming back home. Make sure you don't give it to those poor people who are hanging around at home. So use your common sense. You actually know where all you could have touched. I mean, it's common sense is a very, very important thing than technology, really. It's whole thing of coming home. And with that, I end my opinion, my critique and opinions. It was a very nice talk, Faiz. I really enjoyed listening to you. It was very good. Yeah. If there's any questions, small questions, I can answer maybe 1 or 2 minutes, 1 minute, 2 minutes, so something like that. It's fine.
Sir, the same question which I was asking you. Do you really need this complicated PPE? That is something which comes to my mind.
No, we're wearing it. Everybody is wearing it in my clinic. My prosthodontist is wearing it. My endodontist is wearing it. I am doing it when I do some surgical procedures. My children didn't want to do it, but my wife insisted that they put it. They are also dentists in my clinic. So then they are now wearing it very reluctantly. But if you're just examining a patient, asking him a few questions, assuring him and things like that, you don't need all that, kind of paraphernalia, if you ask me, really. And Faiz, I can't really comment on the lab transfer protocols because I practice only maxillofacial surgery, so I don't even know anything about it.
Well, but I told something really simple, sir, which just simply make sure you put it in a proper cover and clean the outside of the cover and hand it over. Yeah. Instructions, send it by WhatsApp or
everybody's safety. Simple. Yeah, no, I can't comment on this. I really don't know too much about how these things go.
George Paul, sir.
Anand, you wanted to say something? Yeah. Sorry.
Yeah, Dr. George Paul, can you tell me with the pulse oximeter, what is the cutoff value that I have to take up and I have to send the patient back?
Very, very nice question, because there is no cutoff point actually. Now I saw some of the literature which actually said if somebody is saturating at less than 94%, it means that there's something frightening. I saturated at 94. I'm a No, I don't have COPD. I have asthma. I was looking at all the other people who are around. Everybody is at 96, 97. I'm 94. By the way,
Yeah.
I had myself tested for COVID RT-PCR today. I'm negative, so it's a happy day for me today. So
God bless you,
God
sir. God bless you. God bless you.
yeah. So, but
God
the
bless.
thing is, 94, 95 is okay. See, actually, patients don't exhibit.
Yeah.
See, I've been seeing 90, you will never see anything wrong. From 85, people who are otherwise normal, from 85, they start feeling slightly breathless. Moochu vaangu, I mean, Tamil they say moochu vaangu. That, they sometimes try to draw in big breaths and things like that. And you need to be careful when you watch them do that. And if somebody goes into syncope, they will frighten the hell out of you. They can go down to 50, 60 and things like that for a syncope. So, it shouldn't frighten you in that way. But I was reading something. There are people with 60 to 70% saturation walking around, talking on the phone in COVID-19 situations, which is, I don't know if it's true because this was actually told to me orally, but I read some articles which said that you can desaturate up to 80, 85 and absolutely no sign of something going wrong. So I'm not sure it's a very, very specific or a sensitive thing to use, but have it. It's a nice, I mean, legally at least, you have.
Sir, I usually use this in all my LA. Before placing LA, I usually use this for quite a long time. So usually for 95 to 97, 98 is what we usually see. But some patients, at the first time you clip it, it takes 2-3 minutes to settle down to show a stable value. Am I right?
Yeah. That's very important. When you put your pulse oximeter, it doesn't see there's a lag time of approximately 20 to 25 seconds, 30 seconds for your saturation to come up. So don't get carried away by what you see initially. It's very, very important. So it takes
1.5 minutes is fine. Okay.
No, not so long. 30 seconds. 25, 30 seconds. That's
George Paul, sir. Sir, I have a few things to note up, sir. Sir, could you please comment about the beginning of the clinic procedures? Suppose the beginning of the day, we come and open the shutter and on the clinic. What are the protocols we advise? Let's start from there. So I think that part is like it's all once the patient comes.
I think Faiz did a good job of presenting the whole thing, isn't it?
Yes, sir.
Yeah. Okay. In my clinic, one thing that he didn't cover is we have physical distancing. I don't like to use the word social distancing because here we are sitting as a society, not very distant. We are talking to each other and being very friendly. Physical distancing, yes. We have blocked off chairs.
Okay, sir.
But we don't have 6 feet. It's more like 4 feet, 3.5, 4 feet. Of course, ours is a big clinic. Is a
sir, it's not that I'm asking, sir. So the day you open the shutter, like what, how do you aerate? Whether you have any other protocol? What is the protocols we are going to tell the participants? Like because the end of the day we should have a separate protocol of cleaning and disinfection. The beginning of the day we should start up with something because the front office is important. How to maintain the apartment, how to call up. I think that part we should
see, there's
consider.
basically a security person who opens up the shutters. He puts everything out. The first thing he does is completely. It's also done. Last thing that they do also is disinfecting, but they do it again. 2 times or 3 times in a week, we disinfect the clinic with a fumigation, which is a very old technique we're using. It's nothing like what you guys are talking about. What we use is formalin and potassium permanganate disinfection. We're not using aerosols. Okay. All rooms are fumigated that way. When they come in, all of them get, they have to use a sanitizer on their hand. They come in and they are designated seats. All our appointments are taken by telephone as far as possible, but we have 2 waiting rooms. So we also have a place where telephonic received patients are waiting. I don't think everybody has that luxury. We do that. Apart from that, then the receptionist takes over. She keeps some good distance. The table is disinfected. We don't have any barrier or anything. They talk to them. We try to minimize use of paper. So usually they come, they open their page and show, and we tell them what, if they were old patients, they come with their case sheets or any documents and things like that. Paperwork we have tried to reduce to a maximum. Otherwise, I actually go in a little late, so my other staff are actually dealing with very practical aspects of it. But distancing is one thing that we are very for. If anybody is sitting too close, even husband and wife, sometimes they try to separate them, which I suppose it's in a general thing you need to do that. All of them wash their hands. We have a separate bathroom before they go into the treatment area. So all of them wash their hands again after disinfection.
Sir, Eapen sir, you have anything to add on this, sir? The beginning of the day procedure on the front office part.
Of course, the temperature. Okay, we have not been looking at temperature very closely. We have to start that. It's required. It's absolutely required. I think everybody should do that.
Okay. Sir, I would like to stress on keeping a documentation of the identity of the patient. For example,
I'm sorry, you confused me with that. We have a consent form. Yes, we specially made consent. I wrote the consent form. We have a special consent form for COVID time. This thing. We have a history. We ask very personal questions about where they were, whether there was anybody in the family who's had it. We know most of them would lie if they had someone like that, but it's part of our job to think. So we have a tick box. We actually tick it off and make them sign at the end of it. So they're giving actually not an affidavit, but they're giving a declaration. Yes.
Okay. Sir, there is a request. It will be great if you can just share the consent form for all of us.
I think Shah has already shared it.
I already did that. I'll do it again.
I think I missed that. I missed a lot of material.
I'll do it again.
Sir, there is some other concerns from my side. Faiz sir, what would you recommend for the formats the patient carry? For example, the old files, old IOPs, old OPGs, patient mobiles, patient wallets. So what is the recommendation from your side for all those things the patient carries, sir? So I'm putting a specific question, sir. Would you like to filter and collect all these things at the reception? And how do you allow those things inside the OP?
If you want to do that, what I've been thinking of and I'm trying to locate is a small UV chamber where once the patient brings all these things, you chuck it inside the UV chamber, leave it for 5 minutes, or if you have a handheld is not really reliable. If you're having a good chamber, you can put it inside, disinfect it, and then you can give it to the patient. You can switch off your phone and then put it inside the chamber, and then you can disinfect that. That would be a very ideal situation, even for us doctors. We are wearing watch, or we are having a wallet, cell phone, everything, even the spectacles. Before going home, we can just clean it and then take it with us and then go safely.
Going home is fine. Going home is fine.
So, after the procedure,
do you agree that everybody who comes in has to go through a UV chamber?
No, it's not a person, sir. It's the things, materials, what they carry, sir. They carry a purse, they carry a handbag, they carry
I'm not talking about people. No, I'm just saying, even keeping them there, unless you have straight lines, you really can't disinfect to the extent that they all talk about with UV chamber. That's what I understood from Anand. Anand, do you want to say something about that?
Yes.
You're muted. You're muted. Yeah. You're muted. You're muted. You're muted. You are muted. Anand, you're muted. Can somebody unmute him?
Yeah, I'm unmuting him, sir.
Yeah.
No, he's muted again.
This can you hear me? Yeah.
Yes, sir. Yes, please.
See, there are two sizes of UV chamber commercially available. One is around 3/4 meter and one is around 1 meter tall, and with 2 tube lights and a delay on set, and with a metallic frame 3 sides, and you have a glass which is a UV filter. Now, when you open it and place it, it should get adequate exposure to the light, because light always travels straight. Now, if you place a X-ray film or a purse, I think the front part only is getting sterilized. So you can't have a very deep chamber like a mortuary where you can put the thing straight inside. So that is a very big questionable thing. Or you have to flip the side up and down before taking it out. Am I right?
Yeah. Yes, sir. Sir, how about the idea of?
So that is a problem with UV chamber.
Suppose a patient carries a big medical file with a cardiac history or a bypass surgery. How about the idea of digitalizing their documents? For example, if the patient is taking some medication, ask the patient to take a photo and document all the things. Patient need not carry all the medical files. If on the over the phone, if you hear the patient telling he has lot of medical issues, always take a photocopy or the scan and store it as a document. So that will prevent the carrying of the files and other papers.
That is an excellent thing. That's an excellent thing.
So
I think most of the patients nowadays carry the prescription also that way. So I think it's already being done. Yeah.
Yes, sir. So that's perfect.
See, what
and
I
how
do,
about the idea of briefing the patient with the protocols, what is to be done with a small video?
Yes.
Okay.
Yes.
So that is more important because suddenly the patient comes in, you hold them, you enter the patient with the PPE, the reception is there. So a briefing video, if the patient is confirmed to enter the clinic, would be my suggestion of choice. And one more thing, is there any recommendation for the patient to have a PPE if the patient is planned for a procedure, sir? Why, sir?
Personally, I think not.
Okay, sir.
I think not. You need to have some kind of a barrier between the operating person and the patient. Operating meaning, whatever procedures you're doing, which needs to be changed. Because we wearing a PPE, and I tell you, it's terrible to wear a PPE. You can't stand for more than half an hour, 45 minutes.
Yes, sir.
Yeah. That is only for your protection. But between you and the patient,
okay, sir,
I think you need to have something which is inexpensive, because we can't afford to go for very high GSM, these things which can be thrown out.
Okay, sir.
And always
I found that
have a bath, have a shower, take your clothes off and go in, because you've come into a very high risk area. I think you should tell the patients that always.
I found that giving a head cap for the patient is very beneficial, because when you put your arm around, actually,
yes, sir,
that is also helping to reduce the contact.
Head cap for the patient is a good suggestion. I always prefer that for the
head cap for the patient. I am using that, sir. That's very nice.
Yeah, we always use that. So it's not.
Yeah.
Sir,
to the patient. To the patient. Yeah.
I just have a point. I insist that now I work strictly on appointments. I don't have walk-in patients. So all the patients who take appointments are sent a message asking them to forward their Aadhaar number.
Yes, perfect, sir.
Their photograph, because they have to share their identity. That's very, very important. We just cannot take in any strangers.
Yeah.
So they provide their Aadhaar numbers, they provide their photographs, they provide their complete addresses, and we also insist on them providing us 3 months travel information. In brief.
I want to ask you, Prashanth, why 3 months?
Just to make it safe, sir, because see,
all
this is originated about 3 months ago.
That doesn't matter. I mean, someone who's come from Dubai in middle of March, I don't think you need to worry about him at the end of May. I definitely don't.
No. The reason is see what happens. At least the patients will take it seriously. Otherwise, they'll tend to bluff and they'll get away with it. That is the only reason, especially in Kerala.
I don't know if it's a very logical thing, really, because they say 15 days is not enough, 20 days fine, but it can't be 2 months or 3 months.
Just brief. In brief.
Sir,
especially for the travelers, too much of traveling, people who travel a